In this video, I'm going to discuss drowning, the process of drowning, the pathophysiology of drowning, in other words, what happens inside the body as someone drowns, and the assessment and treatment of drowning patients. I'm going to begin by showing you a short video. Here you can see a man who is struggling to keep his head above water in some large breaking waves. If he can't do that, he's going to gradually lose consciousness. And we can see that happen. Now he's face down in the water, no longer swimming, and if he's not completely unresponsive, he soon will be. And if he's not rescued quickly, he's going to die. If he is rescued, what do you do? And what are his chances for survival? That's what this presentation is about. The definition of drowning is respiratory impairment due to submersion under or immersion in water. And like the video, in many cases it requires outside assistance or rescue. The process of drowning has three potential outcomes. You die, you survive with brain damage, or you survive without brain damage. The three critical systems of the body, the respiratory system, circulatory system, and nervous system, all support one another to take oxygen from the air and deliver it to the body cells. The respiratory system pulls the oxygen out of the air and delivers it to the blood. The heart then circulates the blood and the oxygen to the brain and the rest of the body. As the body cells metabolize the oxygen, carbon dioxide levels inside the blood begin to raise until they reach a threshold, and the brain then signals the diaphragm and intercostal muscles to contract and start the breathing cycle again. As long as this continues, the brain functions normally. In drowning, our lungs are not designed to pull oxygen from the water, and as a result, in the drowning process, no additional oxygen gets to the blood. And the oxygen that's already in the blood gets circulated for a while but is quickly used up. And when the heart doesn't get enough oxygen to work, it stops circulating the blood. Likewise, the brain, as it's not getting enough oxygen, stops sending the signals to breathe. And just like the video we just watched, decreased brain function, when people start to drown, you watch them go from awake to unresponsive. And they go through that process of awake to voice responsive, to pain responsive, to unresponsive fairly quickly. And if they don't get oxygen, they're going to die. The treatment is pretty clear. Get oxygen to the patient's brain as soon as possible. So if you are rescuing somebody and you get to them and they're not breathing, if it's possible and you've been trained, go ahead and breathe for them in the water. Get oxygen to them as soon as possible. You get them on shore, if they're still not breathing, then start chest compressions and alternate that with rescue breathing. And if you're successful, they might survive. Let's take a look at a couple of scenarios, 4 different scenarios that you've rescued a patient and then what happens. Okay? So in the first scenario, you rescue someone and they're not breathing, they don't have a pulse, and they're unresponsive. So your treatment is CPR. CPR is a combination of chest compressions and rescue breathing. If they don't respond within 30 minutes, they're dead. However, if they do respond and you get a pulse and respirations back, their level of consciousness is still likely to be depressed, maybe voice responsive, pain responsive, or unresponsive. The second scenario, you're a little faster with your rescue, and this time the person's not breathing, but they do have a pulse, and they're still unresponsive. Well, you breathe for them. You begin rescue breathing. And within a few minutes, they're going to start breathing on your own for most people. And again, their level of consciousness is going to be slightly depressed because they haven't had oxygen for a while. In the third scenario, you're really fast with your rescue, and the person is breathing and they do have a pulse, but their brain function is slightly depressed. They're voice responsive, pain responsive, or unresponsive. And what do? You assist their breathing. Yes, they're breathing on their own, but assist their breathing. Get more oxygen to them. And you'll see why this is important in a little bit. And they should continue breathing on their own, and they may even wake up. Now, not all of these people are going to wake up. Some of them are going to deteriorate and die, and that depends on how much water they've aspirated. Others will wake up. In the fourth scenario, you have a person who is awake the entire time. They have a pulse, they're breathing, and they've either assisted with their rescue or they've self-rescued. And they're now on shore, let's say. And they might be coughing or wheezing. And this could go on for a little while. But they're awake. And the coughing and the wheezing indicate that they have aspirated some water, but you don't know how much. And they're going to assume the position that's most comfortable for them. In most cases, this is going to be sitting. And you can assist people, help them to get into a sitting position. It's more comfortable for them to breathe there. And if you have any supplemental oxygen or adjunct oxygen, then you're going to want to give it to them. And it's possible, depending on the amount of water they've aspirated, that they actually deteriorate over the next couple of minutes or hours, and they could actually die. And so we're going to look at that in a couple of minutes. Before we go there, let's think about the person who has been immersed in cold water. And oxygen or overall metabolic requirements in some patients, not a lot of them, but some patients, may be lowered by immersion in cold water due to core hypothermia or a diving reflex. If this happens, it preserves brain and organ function for 30 and maybe even 60 or 90 minutes. If the drowning patient that you've just rescued is not breathing and they don't have a pulse and they've been submerged in cold water for less than 30 minutes, start CPR. You might resuscitate them. If they've been submerged in ice cold water, for less than 90 minutes, begin CPR. You might resuscitate them. If they have broken through the ice on a river or lake and it's taken an hour and a half to get to them, then you might still be able to resuscitate them. Chances are small. They're better with young people and infants, but it's worth doing. For patients who initially have a pulse and they've been awake and maybe helped in their rescue, and they have a pulse and respirations, or they've been resuscitated and now they've woken up, they may develop respiratory complications severe enough to cause death minutes to hours after the incident if they've aspirated water. So let's take a look at that. So do we know if they've aspirated water? Well, we're given some clues if they've been awake the entire time because they're coughing or wheezing, and that's what happens when you aspirate at least a little bit of water. But here's some information for you. The majority of non-fatal drowning patients aspirate less than 30 milliliters of water. Many don't aspirate any. So, water's not getting into their lungs. That's interesting. 1 to 2 milliliters of water per kilogram of body weight is found in the lungs of fatal drowning patients on autopsy. That means people who have died from drowning, fatal drowning patients, when they're autopsied, have only 1 to 2 milliliters of water per kilogram of body weight in their lungs. That's not a whole lot. Let's do a little math. Let's take a 200-pound man. That's about approximately 90 kilograms. And so if there's 1 to 2 milliliters of water there, that means there's either 90 to 180 milliliters of water in that 200-pound man's lungs. And that's really 3 to 6 ounces of water. That's not a whole lot of water. How come there's not more water? Interestingly, in both cases, water, and sometimes a lot of water, liters of water, enters the patient's stomach. Well, why? What's going on? Well, the epiglottis is a flap that covers our trachea, our windpipe. And when we swallow something, it closes and then it directs water into our stomach. And that's exactly what happens. This is a reflexive action. So in most people, as water floods into their airway, their epiglottis slams shut, like the picture on the left, and they swallow the water. And this reflexive protection typically remains in place until the patient becomes unresponsive. And it works pretty well in both cases. Before we can understand why aspirating water causes so many problems, even a little bit of water, we need to understand the lung anatomy a little bit better. The lungs are essentially tubes that either contain air or blood. The air tubes, the bronchioles, the bronchi, the trachea, terminate in small air sacs called alveoli. And that's where the gas exchange takes place. The tubes and the air sacs are attached to one another by some elastic connective tissue, and they're surrounded by a membrane called the pleura. Of note, the capillaries, the air sacs, the capillaries surround those air sacs, and that's where the gas exchange happens. Here is a scanning electron microscope cross-section image of lung tissue. Notice how thin the walls of each alveolus are. They're one cell thick, and they're fairly fragile. In this cross-section, you can identify some of the anatomy that you see in the drawing. If you look carefully, you'll be able to see some capillaries there. And you'll be able to see identified and labeled some blood vessels and a bronchiole. And that bronchiole goes into an alveolar duct, and that alveolar duct goes into multiple alveoli. Let's take a closer look at an individual alveolus. Here's that alveolar duct. And you can look on the cross-section, you can see it there. Out of the bronchiole, a very small air tube, is numerous alveolar ducts. And the alveolar ducts all go into different alveoli. These sort of flat cells are type 1 alveolar cells. They make up the surface area of the inside of all of the alveoli. And this is where the gas exchange takes place, is through these very, very thin, flat cells. And you can look in the cross-section and see that they're one cell thick. And they're not perfectly round. As a matter of fact, they have sort of like faceted shapes to them. They're surrounded by capillaries, and you can see a couple of capillaries that are labeled in the cross-section. And the capillaries have red blood cells in them, and it's the red blood cells that carry the oxygen around. And then there's connective tissue. And it's sort of, you can see a little bit of connective tissue, but you can't really see a whole lot in the cross-section. The connective tissue is very elastic, and the lungs themselves are elastic. And then you have the interstitium. The interstitium is actually a series of tissues and fluid spaces. It goes from the inside of each alveolus to the inside of the corresponding capillary. And this is the gas exchange, the gases, the oxygen and the CO2, have to be able to get across that space. It's easier to get across that space the thinner it is. Here's a type 2 alveolar cell. And these type 2 cells, there's actually almost twice as many of them as there are the type 1 cells. And these cells are responsible for producing surfactant. Surfactant, it lines the entire inside of every single alveoli in the lungs. And it breaks down surface tension and allows each alveolus to remain inflated, or to be inflated easily. Without surfactant, the actual alveoli would start to collapse. And then you have the alveolar macrophage, the green sort of blob that's there in the bottom of this alveolus. These macrophages actually wander around. They scavenge. They cross through the alveolar ducts and move in and out of all the alveoli. And what they do is they attack any microorganisms, they get rid of any debris. They basically they're the custodians, if you will, of the inside of the lungs. They keep the inside of the lungs clean. Now, they can be overwhelmed, but that's what their job is. So now we can talk about, with that basis in physiology, we can talk about what happens when people aspirate water. So the aspirated water restricts gas exchange. It lowers blood oxygen levels while increasing blood CO2 levels in 3 different ways. It irritates the lining of the bronchioles, causing coughing and inflammation and bronchial constriction. And that's sort of similar to asthma, but not identical. It disrupts and washes out the surfactant. And if you don't have surfactant, the alveoli collapse. It damages the alveolar capillary interface, and it causes inflammation and pulmonary edema. Take a look at these x-rays. From left to right, in the far left one, you have a set of normal lungs. And then in the right two, you can see they're getting whiter and whiter. They're becoming more increasingly opaque. And this indicates respiratory obstruction, secondary to aspirated water. These are actual drowning patients. And what's happening is respiratory function and blood oxygen levels are dropping as this occurs. So what is causing this? Well, the surfactant has been washed out by the aspirated water, and alveoli are starting to collapse. In addition, pulmonary edema is starting to build within a whole bunch of alveoli. In awake patients, life-threatening signs and symptoms typically develop within 2 to 3 hours of rescue or resuscitation. So you see this progression happening in signs and symptoms. So I'm going to talk about each one of these 3 different ways or that aspirated water contributes to this, so you have a little bit of understanding, and we'll look at what you can do to interrupt the process and get oxygen to this person and hopefully help them survive. Now, the amount of central nervous system damage overall due to the lack of oxygen and the corresponding acidosis, and that's the high blood CO2 levels, ultimately determines the patient's outcome, whether they're going to live or not live, whether they're going to have brain damage or not have brain damage. If the period of oxygen loss is limited, the acidosis minimal, or the victim rapidly develops core hypothermia or a diving reflex, the damage may be limited and the patient may survive with no or only minor brain damage. So let's look at bronchial constriction. Aspirated water can irritate the lining of the bronchioles and cause inflammation, bronchial constriction, and coughing or wheezing. Okay, so how does it do that? Here comes the aspirated water. It goes inside the bronchi and it irritates the bronchial lining. And the bronchi go into spasm and inflammation, and that causes some bronchial constriction. You can see that the thickness of the walls has increased a little bit from inflammation, and the bronchi have constricted. And so that's going to make it harder to get oxygen, and that's where you hear the wheezing. And you'll hear coughing because the lining of the bronchioles and the bronchi have little cilia, little hairs, and they're trying to get rid of that water. So what do you do? What kind of treatment? Well, for most of the patients who remain awake and throughout their rescue and have self-rescued or assisted their rescue, they'll be coughing and wheezing, and that will spontaneously resolve in a few minutes. If all the signs and symptoms fully and quickly resolve, no evacuation is necessary. If they don't resolve, if the coughing persists and the wheezing persists, this is cause of concern, and it really warrants close monitoring. If it gets worse, they need an evacuation. And I might start evacuating them now instead of staying in place while I'm monitoring them. I'd start an evacuation. If they start to get worse, then I want to get them out of there. It becomes urgent to get them out of there. Or if they're already pretty bad, it's already urgent. Let's take a look about what happens when the alveoli collapse. So remember, surfactant breaks up surface tension and it prevents the alveoli from collapsing. So normal inspiration is a result of negative pressure inside the chest cavity. So what happens, air is drawn in as the diaphragm contracts downward. So the diaphragm contracts downward and air comes rushing in. That's normal inspiration. It's negative pressure. It's because of the diaphragm has moved downward. And then in expiration, the diaphragm relaxes, and then the air is passively expelled. Well, during this process, on exhalation, the alveoli do not fully deflate, just sort of like this, this small graphic here. So when you blow off the air, when you breathe out, the alveoli only partially deflate. And because they have surfactant, they easily inflate when your diaphragm moves down again. There's a problem when you don't have the surfactant. Remember that aspirated water disrupts and washes out the surfactant, and that leads to collapse of the alveoli. And the surface tension keeps them sort of stuck together, and so they can't inflate on your own. So what this means is that if you want to get those alveoli to inflate again, you actually have to breathe into that person, put positive pressure. Rescue breathing is required to inflate the collapsed alveoli and increase the gas exchange. So this person who is maybe struggling to breathe a little bit, maybe they are voice responsive or pain responsive and you resuscitated them, or maybe you've pulled them out and they're still voice responsive or pain responsive. The reason they're voice responsive and pain responsive is because they're not getting enough oxygen. And even though they're breathing, they're not going to get enough oxygen on their own because some of their alveoli have collapsed. And so you have to breathe for them. You have to inflate those alveoli. So you've got to put positive pressure there. It's not enough just simply to give them some oxygen if you have it. You have to do positive pressure ventilations. The patient is not going to be able to reinflate the collapsed alveoli on their own until the surfactant has been replaced. And if the type 2 alveolar cells that produce the surfactant are damaged, they're going to need time to regenerate. And so that's time that this person does not have. You've got to breathe for them. So what is the treatment? Well, the treatment is positive pressure ventilations. Mouth to mouth, use a simple mask, so mouth to mask, and a bag valve mask if you have those. Those are what EMTs would carry with them, say, on a beach rescue. If you've got some adjunct oxygen, and in the back country you're not going to, but you might in the front country, then you want to use that because remember, the problem is you need to get, and the solution to the problem is getting oxygen to the person's brain. If they don't have a pulse, you've got to circulate that oxygen, so you need chest compressions. So let's say you get their pulse back and they start breathing spontaneously, they need an urgent evacuation. So they may even wake up, but they still need an urgent evacuation. You don't know if they're going to start going back downhill or not because you don't know how much water they've aspirated. So let's talk about a little bit about pulmonary edema. So aspirated water damages the alveolar capillary interface, and it causes inflammation and it thickens the interstitium. Remember, the interstitium is that distance that the oxygen and carbon dioxide have to cross in order to get into the bloodstream for oxygen and to be excreted for the carbon dioxide to get back into each individual alveolus. Subsequent dilation of the pulmonary capillaries will cause plasma to leak into each alveoli. When the surfactant mixes with the plasma, foam is created, and that issues from the patient's mouth and nose. So foam, if you see it, is an indication of pulmonary edema. If you don't see it, it doesn't mean that they don't have pulmonary edema. It just means that the pulmonary edema is not quite that advanced. So let's take a look at this. So you aspirate water, and that incoming water disrupts the surfactant. And in this drawing here, the surfactant are these dots, and there'd be thousands and thousands and thousands of those dots in each alveolus. Okay, so it disrupts it. It washes it off the surface of each alveoli. Now the water is actually absorbed through the membranes into the capillary beds. And the capillaries dilate and the alveolar wall breaks down and plasma starts to leak into each alveolus. As the plasma leaks into that, it will mix with the surfactant and foam is created. And that foam is going to issue from the patient's mouth and nose. What also happens due to the inflammation is that the interstitium swells and the distance between the capillary beds and the alveoli increases, making it more difficult for the gas exchange to take place. So here is the edema, the plasma that is leaking in from the capillaries, and then that plasma mixes with a surfactant and it creates foam. And here in this short video, you can see as this person's doing chest compressions, that foam is just being pumped right out of this person's mouth and nose. Now that foam is coming from the airway. It's the mixture of the plasma and the surfactant. Okay, it's not vomitus. It's not water coming out of the stomach. It's coming from the lungs. So from a treatment perspective, you need to breathe through the foam using positive pressure ventilations. Ignore it. Don't roll them on their side. Don't try to wipe it away. It will keep coming. It's just going to keep coming. And if you're trying to suction it, you're not pushing air into the person's lungs, inflating those alveoli and forcing oxygen into their bloodstream. So what you need to do is ignore it and breathe through it. If you have adjunct oxygen, great. That'll help. And of course, you do chest compressions if they don't have a pulse. Now remember, there is water in this person's stomach. And at some point, doing all those chest compressions, or if they start to wake up or you get a successful resuscitation, in any of those cases, they're likely to start vomiting it out. And there may be vomiting other stuff that's in their stomach. That's when you need to roll them. So make a clear distinction between foam and water coming out of their mouth or other vomitus. If you successfully resuscitate them, begin an urgent evacuation. So your basic life support treatment. A review here. If the respirations are absent, begin rescue breathing. Focus on getting oxygen to the patient's brain as quickly as possible. In many cases, patients will typically respond after a few breaths. If you've been trained, and if you're a river guide or a kayaking guide on the ocean, a touring guide, you should be trained to rescue people and breathe for them while they're in the water. Get that training. It could save somebody's life. And also remember that the epiglottis, which is that flap that covers the trachea, is connected and attached to the tongue. And you want to combine a head tilt, chin lift, jaw thrust maneuvers, all three of them, a triple maneuver, if you will, when you're doing rescue breathing to ensure that the airway is open and your breaths are getting into the patient's lungs. Remember, they've got to get oxygen in there. If your rescue breathing is not effective enough to inflate their alveoli, then there's no oxygen getting to their brain, and you've not interrupted the process. Remember that a pulseless drowning patient, if they've been submerged in cold water for less than 30 minutes or in ice cold water for less than 90 minutes, you start CPR. And we suggest that you start with 5 rescue breaths. Remember, oxygen is really important. They don't have it. So make sure you get a lot of breath into them, a lot of air into them, a lot of oxygen into their lungs and through into their capillaries, and then alternate 30 compressions and 2 breaths as you begin your CPR. Realize that less than 10% of drowning patients need defibrillation. It is not a heart problem in most cases. There are people who do have a heart attack when they are thrown into water, but for the most part, it is an oxygen problem, and you got to get oxygen to the person's brain. If you have supplemental oxygen, use it. If the patient is mental status or is their level of consciousness is down, if they're voice responsive, pain responsive, or unresponsive, assist their breathing using a bag valve mask or connects oxygen to the oxygen port in a simple face mask. If you've got oxygen, use it. If the patient is awake and you have oxygen, use a non-rebreather mask or nasal cannula. And if you've never been trained in oxygen use and you carry it, get trained in it. Stop your resuscitation efforts after 30 minutes. The person is dead. If you haven't resuscitated them and you've been working on them for 30 minutes and they have got a pulse back and they're not breathing on their own, they're dead. If the patient is voice responsive, pain responsive, or unresponsive, and trauma is a potential mechanism, as best as possible, support their spine during rescue and transport. However, spinal support should not delay your resuscitation efforts. Don't try to hold this person's head still. Get them out of the water as quickly as possible. Be as gentle as you can, but you got to do it fast. You need to get oxygen in. So don't let that slow your resuscitation efforts. Anticipate foam is going to issue from the patient's mouth and nose, and vomiting during resuscitation. So breathe through the foam, roll and suction any true vomit or water. Breathe through the foam. And finally, you've resuscitated them, and if they're cold, if it's cold out, the water's been cold, we'll then treat for hypothermia. Now, this is post-rescue or post-resuscitation treatment. They're breathing, they have a pulse at this point. So continue to treat for hypothermia. Continue to be prepared for vomiting. Rule out any traumatic problems as you usually would if the patient is awake. Even with poor water quality, patients who self-rescue are typically at a pretty low risk of developing pulmonary edema, 0.6 to 5%, pretty low. So if a patient is asymptomatic, in other words, they don't have any symptoms and they have a normal mental status, no evacuation is needed. They're coughing and they're wheezing, resolve in a couple of minutes. It's no worse than if they were drinking some water and chugging it and got it down the wrong tube. Okay, that's your sort of guideline. Begin a non-urgent, we call it a level 3 evacuation, for patients who present with mild signs and symptoms after rescue that don't immediately resolve. So coughing or wheezing, that continues to persist. Or they complain about some really mild respiratory distress. Or you have a stethoscope or you put your ear to their chest and you hear this crackling noise. That's indication that there's air moving through some pulmonary edema in their lungs. If their mental status is not quite there, or if they've presented with some foam in their upper airway, you need to evacuate these people. Start the evacuation now. Think about it as non-urgent and monitor them very, very closely. If their signs and symptoms start to worsen, upgrade them to an urgent evacuation. In other words, get them out of there as fast as you can. You may not be able to get them out fast enough and they may die. Realize that what you do in the field with giving them oxygen, breathing for them, is going to have the largest impact. The hospital can do some things, but the best thing that can be done is what happens in the first couple of minutes in the field. It's up to you, really. Begin an urgent evacuation for all awake and asymptomatic patients after a successful resuscitation. So anybody you've resuscitated, if they come back and they wake up and they don't have any other symptoms, well, it's still an urgent evacuation. Okay, they were out long enough to need resuscitation. And in many cases, some of those people will have aspirated water, and we don't know how much water they've aspirated. So let's get them to a hospital. Upgrade to a really very urgent evacuation if they presented with foam in their upper airway, or they develop a severe cough or presented with it after the resuscitation, or they have a moderate or severe respiratory distress, or if you're carrying a blood pressure cuff and they have low blood pressure. These are poor indications, a poor prognosis. This is really important to get this person to the hospital, and they may well die anyway. Now, last thing, although poor water quality increases the chance for pulmonary edema and subsequent respiratory infections in non-fatal drownings, prophylactic antibiotics don't do it. Wait for a couple of days until you see that the person actually has symptoms. They have a fever, they have some sputum, they have abnormal lung sounds. That's the time to give them antibiotics. And ideally by that time, it shouldn't be you that's giving the antibiotics. It's probably someone in the hospital. Let's take a look at a couple of videos for a minute. So in this video, and it's slow motion, here's a kayaker that bumps up against an undercut rock, and that his whole kayak and himself gets sucked underwater, pinned up against that rock. And he's struggling to get out, and he has a GoPro on it, so you can sort of watch this happening. Now remember, this is slow motion. So he's pulling his spray skirt, and those of you that are paddlers, you've done this in many cases. I know I have. Struggling for air, getting back up, not being able to reach the surface, missing my roll. So he's trying to get to the surface. He wants oxygen pretty bad. His head pops up. Does he have enough time to get a breath in? Maybe, maybe not. But he goes back down again. So maybe he has enough time, maybe he doesn't. Did he aspirate some water if he didn't have enough time? Maybe. And he's under the water again, struggling to get up to the top. Okay, he gets to the top. All right. The question is, if he's rescued unresponsive with no pulse or respirations, what do? And the answer is CPR. You do CPR. Rescue breathing first. 5 breaths, get good breaths in. Start your CPR. And ideally, if you rescued him quickly enough, you're going to resuscitate him and he'll wake back up. And that means that we need to have an urgent evacuation. Get him out of there as fast as possible. And his ultimate survival on how well he does is going to depend on how fast you got oxygen to his brain, as well as how much water he aspirated. Now let's change that scenario a little bit. If he's rescued awake and coughing, maybe wheezing a little bit, how does that change the scenario? Well, if he's coughing and he's wheezing a little bit, you know that he's aspirated some water. But he's also has a pulse and he has respiration. So there's a small chance that he's going to deteriorate. But if his coughing resolves and he stops wheezing in a couple of minutes and he feels normal, he acts normal, he doesn't have any respiratory distress, then he doesn't need an evacuation. He's going to be fine. But really monitor him closely to see, especially if he still has a sort of a persistent cough every now and again, or maybe the wheezing doesn't completely go away and he feels a little bit tired and he's not quite with it. That's cause for concern. You need to get him out of there. And if it worsens, it's really important to get him out of there quickly. So he's got a really good chance for survival without any brain damage, but I am concerned about him. He has suffered a drowning event. Ideally, it will be a non-fatal drowning event. Let's take a look at another scenario. In this scenario, you have a woman who is unresponsive and pulseless and not breathing in the ocean. And you can see the lifeguard has pulled her up on top of a surfboard, and 2 other people are stabilizing the board as he's breathing for him. The other 2 people are towing the board in, and they get through the surf. You can see one person wants to do some chest compressions, and the other say, no, let's get her out of here fast. Let's go. Let's get to shore. And there's other lifeguards who have already been setting up, getting some oxygen ready, plugging it into a bag valve mask. That's what you see happening right now. He got a breath or 2 in them, and oxygen is being turned on, and he starts to breathe for her, and they're squeezing that bag, and she starts to breathe on her own. And then a few seconds later, she vomits up water, and they turn and roll her. And here you can see her eyes are open. Now, she's probably starting to wake up right now, and so they're talking to her. So here's someone who started out no pulse, no respirations. They started rescue breathing during the rescue while she was in the water. So they started to get oxygen to her brain really, really quickly, got her on shore, continued the rescue breathing, added oxygen to it. That helps. Chest compressions to circulate some more of that oxygen, and she woke up pretty quickly. She resuscitated pretty quickly. Now, she needs an urgent evacuation. Her chances are pretty good that she'll survive this without any without any brain damage. And that all depends on how much water she's aspirated. So get her to the hospital and you'll find out. Time will tell. So hopefully in this presentation, you've learned a little bit about what happens when people drown and what you can do to interrupt that process. get oxygen to the brain.